Hey there, class. Welcome back to week 2. We are going to continue with the medical and surgical section. And for week 2, it's chapter 34. I highly recommend that you have your textbook with you when you're listening to this lecture so you can make notes in your book, or if you whatever method you use of taking notes, because there may be some aha moments as we go through these slides. There are things that I specifically share with you that are going to help you understand the complex nuances of ICD-10-PCS. So today's chapter is going to be all about the medical and surgical section. And this is the PCS section that you're going to use most often. So my goal is to help you build a consistent coding routine. We're going to learn how to identify the correct section and body systems. So you start on the right table, you get started on the right foot. And also, we're going to determine the correct root operation by focusing on what the provider did, not what they called it. As I briefly discussed in last week's lecture, we don't necessarily go by what the provider called the procedure, it's what the provider did. We're going to learn continue to learn how to use anatomy to pinpoint the exact body part that's treated based on that operative note. We're going to identify the approach. Was this an open, a percutaneous, an endoscopic, natural, etc., from how the procedure was performed. We're going to use that same workflow every single time. We're going to go by section, body system, root operation, body part, and approach. We're going to also identify if there was a device left in the body after the procedure. So we're going to look at the device value. Was there an implant, a graft, a stent, a drain? If nothing remains, remember the device is usually a Z. We're going to choose a correct qualifier when PCS requires extra detail, like type, site, specifics. And if there's no extra detail, we're going to use that Z. We're going to apply the rules for multiple procedures, code each distinct objective body part approach, and understand how to handle discontinued procedures based on the documentation and the facility's policy. So when we say facility policy, we're talking about the individual policy that may exist at the facility that you are coding for. Every facility has a policy and procedure in place, and if they don't, then you would default to the official ICD-10 PCS coding guidelines, the NCD, LCD, Medicare, etc. We're going to apply the rules for pulling it all together to build a complete 7-character PCS code. By verifying every character, we're going to look at the section, the body system, the root operation, the body part, approach, device, and qualifiers. Okay. So some of the key terms that we have are approach, character, and root operation term. These are must-know terms. The root operation term means that this is the PCS word that describes the objective of the procedure. What was the provider intending to accomplish? Were they removing something? Were they draining something, repairing something, replacing something? This is often a make or break decision in the code building process. Next, we have approach. This tells how the surgeon got to the site. Is this a percutaneous procedure? Is this a percutaneous endoscopic? Is this via natural opening, etc.? We're going to look for clues like incision, scope, catheter, or natural opening in the op note. Character is the PCS codes, remember, have 7 characters. And each character has a specific meaning. The key takeaway is if you're not picking a code, you're building it one character at a time based on that documentation. So let's move into 34.1, the starting point for every medical and surgical PCS code, characters 1 and 2. Character 1 tells us the section. For this chapter, we're working in medical and surgical. Character 2 tells us the body system, which narrows it down to the correct set of tables. Think of these as your address in PCS. If you choose the wrong section of the body system, you can build a perfect code from the wrong table. So we always confirm characters 1 and 2 before we make the root operation or approach decisions. The first character equals the section. For the medical and surgical section, the first character is always 0. So anytime you're coding a medical, surgical, inpatient procedure, your code will always start with 0. A quick tip, say 0 equals medical surgical to yourself as a checkpoint before you go any further on the tables. On this slide, we see that there's the medical surgical body system values for character 2. Character 1 will be 0 for medical surgical, then character 2 narrows you to the correct table group. Nervous system, cardiovascular, respiratory, hepatobiliary, etc. A few practical tips you can use from this list is 1, treat each character 2 like a sorting step. Pick the body system before you think about the root operation. You want to use anatomy and the op note. You want to ask yourself, what system does the treated body part belong to? Watch the characters. PCS uses numbers and letters, so B is a valid body system value. Respiratory, not 8. Verify in the table header. The table title will confirm you're in the right body system before you build the rest of the table or build the rest of the code. You do not need to memorize every value. You do not need to recognize the common ones. You do not need to memorize every value. Okay. In fact, I highly discourage you from memorizing anything because it always changes. Number 1. Number 2, there's so much involved. So unless you're doing the same procedure over and over and over and you have that consistency, don't bother memorizing. But what you do need to do is you do need to recognize the common ones quickly and confirm the rest by checking the tables. The key takeaways for character 2 is your organizer. It tells you what table family to use before you choose root operation, body part, or approach. A few quick reminders as you use these. M equals the bursa, the ligaments. R/S equals joints, upper versus lower. And then you have TUX, urinary, reproductive, etc. So it's important to understand these body system characters in order to go to the specific correct character for which you're coding. The ICD-10-PCS official guidelines for coding and reporting specifically state Section 0, Guideline B2, Body System under General Guidelines. And the reason I'm highlighting this is quite simple. When you're unsure which body system to use, you don't guess. Never guess. You go back to the guideline and let the rules drive your choice. Let the rules be your navigator and your compass. This is the same habit you used in ICD-10-CM. You want to look at the guidelines first, then the code selection. As we work through examples, we'll apply B2 to confirm we're in the correct body system before we move on to root operation and to body part. Now that you can reliably choose characters 1 and 2, we move into 34.2, which is the decision that carries the most meaning in PCS, the root operation. Character 3 answers one question: What was the objective? What was the objective of the procedure? Not the approach, not the device, what the provider intended to accomplish. This is where PCS shifts from finding a code to interpreting documentation. We're going to practice reading the op note and translating it into correct PCS root operation terms. Once character 3 is correct, the rest of the code becomes much easier to build. You're almost done. But it's imperative that you get that root operation correct. So here we have medical surgical root operation terms. These are common options for character 3. A key point: a root operation is based on the objective of the procedure. The surgeon's wording may vary, but PCS wants you to code what was actually done. As you can see on this list, start grouping them in your head. So you want to think about take out, eliminate, destruction, detachment, drainage, excision, extirpation, extraction, fix, change, structure, which would be dilation, division, fragmentation, fusion, put in, create, would be creation, insertion, move, reroute, bypass, reattachment, and so forth and so on. So understanding these root operation terms is imperative. Understanding the process, the steps involved is, you'll find when you take the CPT class in the spring, different terminology once again. It would be really nice if it was all uniformed and standardized, but unfortunately it is not. So we have to be the ones to distinguish the differences. So understanding these root operation terms, definitely put this at the top of your list. And again, once we go through these additional ones, so these root operation terms: release, removal, repair, replacement. So, think of replacement as putting in a device that takes part of a body part: joint replacement, valve replacement. Reposition. What does reposition mean to you? So that's an easy one, because reposition seems logical. It's moving a body part to a new normal location. So if you have a fraction or a fracture, reduction, repositioning of an organ, resection is removing all of a body part. Restriction, restricting something, so partially closing and opening, or a lumen. A banding, a narrowing. Revision would be adjusting a device that's already in place. Maybe the patient has a catheter in place, or a shunt revision. So, again, spend time on these root operation terms, because these are going to be the key to getting to your correct code. So this slide is somewhat of a roadmap for the official PCS guidance for character 3. In the ICD-10-PCS guidelines, look at section 0, medical surgical B3, root operation. These rules are here to help you with the exact spots where you are going to get stuck. When two root operations feel like they could both work, you need to apply the decision rules. You need to apply the coding guidelines rules. You're going to lean on these guidelines. So if we have multiple procedures, how many codes are you going to report? What about if there's a discontinued, incomplete procedure? What do you do when the intent wasn't fully carried out? Biopsy guidance, and when biopsy is coded separately versus included. Overlapping body layers, which body part to code when layers are involved. It's common to see either or choices. when you're looking through these coding guidelines. For example, excision versus resection. Was it some or was it all? Occlusion versus restriction, especially for embolization. Release versus division, repositioning, etc. The bottom line, the key takeaway for this is I want you to understand that root operation selection is not guesswork. When you're torn between terms, you go to B3 and let the guidelines settle it. Let the guidelines help you with that process. If character 3 answers what was done, character 4 answers where it was done. This is where your anatomy, knowledge, and your operative note really matter. You're looking for the exact structure treated, not the diagnosis, and not the general area. You don't want to just get into the ballpark. That's not good enough. You want to hit it to a specific location. A coding habit, a coding tip for character 4, you want to identify the specific body part. Was this an artery versus a vein, a lobe versus whole organ, a joint versus bone? You want to confirm details like laterality, segment, and level when the tables require it. If documentation is unclear, you want to stop, verify before you lock in the body part value. Once we have that correct body part, the remaining characters become more straightforward to build. Documentation can be more specific than PCS body part options. Sometimes the provider names a very specific structure, but the PCS tables don't go into that exact same granularity of detail, right? When that happens, you do not create your own body part choice. You want to select the closest PCS body value that includes that documented site. An example on this slide, the surgeon documents biceps femoris, but the muscle's body system, K, may not list that specific muscle. Since biceps femoris is the upper leg, you would code the body part as the upper leg muscle. Here's a rule of thumb. You want to code to the most specific PCS body part value available that accurately includes that documented anatomy. So there are going to be times where PCS is not as specific as the documentation that the surgeon is providing, which is frustrating. However, when you know your anatomy, you're going to know that, oh, that's in this section or that's in that section. And you will find it, the more you practice, the easier it becomes. So this is your reference point for the official rules for character 4. These guidelines tell you how to choose a correct body part value when the documentation and the tables don't line up perfectly, which is going to happen a lot. B4 is especially helpful for common tricky areas, including branches of body parts. That's when a structure has name branches. Bilateral body part values, when PCS offers a single value versus coding each side. Coronary arteries, how to select the correct coronary body part. Tendons, ligaments, bursa, fascia near a joint, and subcutaneous fascia over a joint. Fingers, toes, upper versus lower intestinal tract, etc. Now we're going to move into character 5. This is how the provider reached the site. What is the approach? And that's based on technique and access, not the diagnosis and not the root operation. As we go through approaches, you're going to train yourself to look for a few documentation clues. First, was there an incision? Was this open? Or was there a needle catheter puncture? Percutaneous. Was there a scope used? Endoscopic. Or not? Was entry through a natural opening, the mouth, urethra, rectum, with or without a scope? Once you can identify these cues correctly and quickly, character 5 becomes very straightforward, and it's a repeatable decision. Approach is determined by how the provider accesses the site. Open is when an incision is made to directly open and expose the site. Percutaneous is entry by puncture or minor incision through the skin. This could be needle, catheter, or no scope. Percutaneous endoscopic is entry through the skin with an endoscope. Laparoscopic is here. Via natural or artificial opening is entry through a natural opening, the mouth, urethra, rectum, or an artificial opening, or such as a stoma. No scope. Via natural or artificial opening, endoscopic is through the natural or artificial opening, but is using an endoscope. So think of colonoscopy, cystoscopy, endoscopy. Like when you have an EGD, esophagogastroduodenoscopy, that's with the scope. External procedure is performed on the skin or externally accessible site, no entry into the body. Look for clues in the note: incision versus puncture, scope versus no scope, natural opening versus through skin. So according to the coding guidelines for character 5, the guidelines clarify the approach choice when the documentation describes a technique that feels mixed or not obvious. And this is especially useful for those common problem areas, such as open approach with percutaneous endoscopic assistance. If a procedure is coded as open, even if a scope is used to assist, it would still be considered open approach. External approach confirms when a procedure is truly external, performed on an external site with no entry. Percutaneous procedure via device, this is when access is through an existing device, for example, working through a catheter or a tube, and you need to confirm the correct approach. The bottom line is, if you're torn between true approaches, go to B5 and let the guidelines help you decide. Next, we're going to move on to character 6, and this answers the question: was anything left in the body at the end of the procedure? If it's yes, you code the device value that best describes what remained. Was there a stent, a graft, a drain, a prosthesis, etc.? If nothing is left behind, character 6 is usually Z, no device. The key habit here is you don't want to code the tools used during the procedure, only what was left in place after the procedure is complete. So we do not code any temporary instruments or supplies used during the case. So if there's a scope, a clamp, sutures, guide wires, that's part of the procedure. We have to remember here that we only code things left behind if there's a stent, a graft, a drain, a mesh, prosthesis, or implant. If nothing stays in, it's typically 0. Now, a note regarding Penrose drains. If a Penrose is left in place to help drain the site after the procedure but is going to be removed, it's a temporary drain. It's not something that's permanently left in place after the procedure. So when we mention drain, think about drain for like cerebral spinal fluid that is left in place for for encephalopathy, or for some other procedure that may require a drain be left permanently in place, but not a temporary drain. So for the coding guidelines for section B6 device, this is the rule set you use when you're unsure whether something counts as a device, or which device value to pick. 2 key reminders from this section: a general device rule: report any device only if it remains in the patient after the procedure and is a permanent part of the I guess you want to say of the person, stays in permanently. A drainage device guideline clarifies when a drain is coded as the device and when you still use Z because nothing remains. And if you ever feel stuck, go to B6 coding guidelines and it will help guide you. So this character 7 is extra detail. It's used when PCS needs just one more piece of information to fully describe the specifics of the procedure. Often something like type of graft, diagnostic versus therapeutic intent, or any other specific attribute that's defined in the table. Most of the time there's no qualifier and you're just going to use Z, no qualifier. The important thing to remember with this is that you want to check the table. If the qualifier column has options, you must pick the value that matches the documentation. If it doesn't have any detail, you want to use Z. So for character 7, it's always required. You always have to code, always have to capture that character 7. Don't leave it blank. If the table does not require extra detail, put a Z on it. No qualifier. It's not applicable. Sometimes a qualifier does not add meaning, or does add meaning rather, so you must check that operative note. Look for those specific details that the table may be prompting you for and choose the correct qualifier value. The bottom line is always look at that qualifier column in the table. It's either Z or it's document driven. So make sure that you take it, all those characters to the number 7 to the qualifier placeholder Z. All right, what happens when you come across multiple and discontinued procedures? There are two key ideas here. Multiple procedures happen and you may need 2, 3, 4, 5 PCS codes. When distinct objectives are performed, you're going to have to look at expanding beyond just one code. Common triggers are different in root operations, a different body part, a different approach, or maybe a separate reportable procedure done at the same encounter. Of course, our goal as coders is to capture the unique procedure the documentation supports. We also come across discontinued procedures. Sometimes a procedure is started, but it's not completed for whatever reason. And in PCS, you're going to code based on what was actually performed, not what was planned. This means you read the op note carefully and determine whether any definitive root operation was accomplished or whether the work stopped before the intended objective was reached. In this section, we'll practice separating one case into the correct number of PCS codes, and we're going to use that documentation to decide what counts. So when we have multiple procedures, and we need more than one PCS code, this can be you have the same root operation, different body parts, different body part values. You're going to report 2 codes, one for each body part. If you have the same root operation, different sites within the same body value, you're not going to report the same code twice. You're going to add a brief note statement to clarify the 2 sites. And of course, it's based on your facility's practice as well. Different root operations on the same body part report 2 codes, one per root operation because the objectives are different. Approach conversion or approach conversion? Yeah, conversion. If the case starts with one approach and converts to another, code what was actually accomplished with the first approach and code the procedure performed with the second approach as a separate code. The bottom line, the takeaway from this is PCS is objective based. When the body part value, objective, i.e. root operation, or approach changes in a meaningful way, you're often going to look at multiple codes. If you have a discontinued procedure, there are key rules that you need to follow. If a procedure is started but stopped before the intended goal is achieved, you're not going to code the planned procedure. You're going to code the root operation actually performed. You code the root operation performed and supported by the documentation. So you're going to follow the documentation to the highest level of specificity and code it as such. So think of it this way. When you're coding a discontinued procedure, think of your focus shifting to what objective was actually accomplished before the case was discontinued. If nothing was accomplished, you code what was truly done up to that point based on the documentation. All right, now we're at pulling it all together. This is where you take everything you've learned and build a complete 7-character PCS code from documentation. So you're going to use this checklist every single time. You're looking at the section, medical surgical, 0. The body system, this is character 2. The root operation, what is the objective of this procedure? What is the patient going into the OR for? What was the body part treated? What is the approach? How did the surgeon access the site? Was a device left in place after the procedure was completed? What is the qualifier? Remember, this is character 7, and it's always, always, always required. And this is often a Z. Your goal is to be consistent. Read the op note, make one decision per character, and confirm each choice on the table before you finalize the code. So it's a stepping stone. You're taking one step at a time. You're not taking it all in one gulp. You're breaking it down into little parts. 7-step process. So once again, you're looking at the section of the PCS book. You're looking at the body system being treated, the root operation term, the specific anatomical body part, the approach, the device, and the qualifier. So for ICD-10-PCS, you have to have a different mindset, and you're probably quickly learning that. This is so different from CM. You're not just looking up a label, you're interpreting the operative note and building the code character by character. It's a stepping stone process, building blocks, tables, and it's based on what was actually done. It's not what the intended procedure was, but what was actually done with the patient on the OR table and what was documented by the provider. This is new, but like with ICD-10-CM, it's new. It's a new way of thinking. It's something new to wrap your brain around, but the more you practice, the more comfortable it becomes. Remember that ICD-10-PS is used for inpatient hospital procedures only. So within PCS, the medical and surgical section is the most common section you're going to code from because it captures the largest share of procedures performed on hospitalized patients. So that concludes the end of Module 2, Week 2. Module 2. Well, Week 2. Lecture, and if you have any questions, remember you can reach out to me directly. You can post it under the Q&A on the class, or you can set up a time to meet with me with office hours. Excuse me. All right. So it's so good to see you for this week. I apologize for the sneeze. Have a great week, and we'll see you next time. All right. So take care. Bye-bye.